So let's look at the possibility of vertical transmission, which is from a pregnant mom down to an unborn baby. There's mixed research on this. One study says that it can happen, the other study says it cannot, so we don't really know at this point. What I think is more likely is the baby comes out, mom has corona, she's asymptomatic. The baby, of course, she wants the baby up on her chest, and then she breathes on the baby. She's not wearing a mask, and then the baby gets corona. That's a more likely explanation. From the time that somebody starts symptoms, you start with a fever, it moves to a dry cough. This is the timeline if you're going to progress to a severe form of the disease. So within 5 days, you'll start to have shortness of breath. Then 2 days later, on average, you'll be admitted to the hospital from the shortness of breath. Then a day after that, you end up in the ICU on a respirator. So within 8 days, you can go from being normal to being on a ventilator. One of the things I want to point out is it tends not to have a runny nose, tends not to have a sore throat. Those can happen, tends not to have sneezing, but those are more symptoms of a cold than they are of the coronavirus. So 88% of people have a fever as a first presenting symptom, and then they move to a dry cough, and that's about 2/3 of the people. And then only less than 20% will have shortness of breath from the coronavirus. So it goes with most people have mild disease. Here's a comparison chart between COVID, colds, and flu. You can look through, you can take a snapshot of this, screenshot, and just look at the difference. I already mentioned that we tend not to get sore throats with corona. We tend not to have a runny nose with corona. So what we get with the COVID is dry cough, fever, and breathlessness. Digestive symptoms have been reported, and about half of the patients with COVID, digestive symptoms as abdominal pain is an indicator, can be an indicator of a worse disease. So patients with corona frequently have digestive symptoms, and those with those symptoms have a worse clinical outcome. Doesn't mean that you're going to end up on a respirator, because half of the people have abdominal pain, yet only 19% end up with shortness of breath. It doesn't mean that you're absolutely going to have a bad outcome. It just tends to suggest it. So how long do symptoms last? For mild cases, it's about 2 weeks, which is in line with a common cold, and the severe to critical cases are 3 to 6 weeks. This is from Worldometer. This is showing that the elderly are having a more difficult time with this disease. You can see that much higher incidence of death once you get into the 60, 70, 80 years old. They're going up dramatically. Very few children have died from 0 to 9, and very few midlife people are passing away from this disease. Italy is starting to look at the people who have died, and if there were any complicating factors, you can see that 0.8% had no other diseases. So those who were healthy were not dying. Only 0.8% of the people who died in Italy had no underlying disease. We can see that if you had 1 disease, 2 disease, 3 disease, you were much more likely to die. This is why it's important that if you have autoimmune conditions, you're not healthy for whatever reason, you want to quarantine yourself and consider yourself in that severe risk category. This is also from the Italian National Health Institute. The average age of those who died from the virus in Italy is 79.5 years old. 17 people under 50 died from the disease, and all of Italy's victims under 40 had been males, and they had serious existing medical conditions. We do see a higher incidence in males than in females. This likely has to go with the ACE receptor that's in the lungs where the virus is attaching. Men tend to have more hypertension. I'm speaking outside of my knowledge base for pediatrics, but they tend to have more hypertension. That could be related to the ACE receptors, and then more ACE receptors, more spots for the virus to attach to, and then that leads to a higher incidence of death. We can see that cardiovascular disease is the leading cause of a pre-existing condition, as well as diabetes, followed by chronic respiratory conditions. The U.S. is confirming what we've been seeing worldwide. This is worldwide numbers. This is the research that's being done here in the States, and we can see diabetes, chronic lung disease, and cardiovascular disease are the top comorbid or underlying conditions. Individuals taking Glucosteroids, you'll take those if you have asthma, if you have autoimmune conditions, if you have eczema, if you have severe allergies, you can be taking this. It does put you at a higher risk for COVID, because that does reduce the effectiveness of your immune system. That's why we use them for autoimmune diseases, because it turns down your immune system so you're less affected by the disease. Here are the criteria for screening for COVID. Again, I'm not going to go through this, but you can just take a screenshot or you can Google it. This is from the CDC, screening for COVID-19. And the FDA is looking at a fast, rapid testing system. Right now, the testing system is nasal swab, and it can take anywhere from 5 days up to 14 days to get a result. This is going to be a test that you can have a positive result within 5 minutes and a negative result within 13 minutes. There is a concern with this test. This is developed by Abbott Labs. They want to make sure that when you have a positive, that it's positive to the COVID-19 virus and not something else. So they took samples of all the different COVID samples from around the world, and they used them in the matrix that they used for this test. But that matrix is only good as of March 20th, 2020. This virus is mutating. So the further out we get from March 2020, the more likely that this test will not catch new mutations of the virus. I want to emphasize it, the 2020, March 20, 2020. And here's a Yale professor, Yale School of Medicine, Dr. Krumholtz, who said there's very little known about how rapidly the SARS-CoV-2 genome mutates and how this affects the transmission and the disease severity. So it's a moving target, is what he says. So it limits the functionality and accuracy of the test. Also, to make sure that it's not cross-reacting with other coronaviruses, because corona is a very common human virus that causes mild disease, they did a computer analysis. And the shortcomings of the computer analysis is that it's not a clinical study. It's not a clinical correlation. It's like using a weather model to say what the weather's going to be like today. The computer can generate a likely probability, but it's not an absolute. It's not until it actually happens and you have a clinical trial where you know the absolute. So this is another possible shortcoming. We could be getting a lot of false positives or false negatives because of this situation where we're doing tests inside of a computer instead of actually doing clinical tests. We have a new antibody test that the FDA has authorized. Doesn't mean they've approved it, it's authorized. This is just to see if you've had it in the past. This way a lot of people are saying, well, I was sick back in December, I was sick in January, it likely was COVID. Remember, only 10% of those who feel that they have COVID are actually testing positive, at least here in Florida. So this test will be able to tell us if you've actually had it in the past or if you currently have it by antibodies. Here's the risk factors I was talking about, the high risk. Remember, autoimmunes and people who have chronic disease should consider themselves in high risk. You can take a screenshot of this and understand what risk profile you might fall into. Low risk is if somebody walked through this room right now and had COVID, that's a no risk. Briefly walking by a person who tested positive for COVID-19 was not experiencing symptoms is not a risk. So that's a low risk, so you just put it in perspective. So there are some sources of optimism as we're starting to learn how to treat this disease. The hydroxychloroquine is being used as a frontline medicine and has been used for about 3 or 4 weeks now as a frontline medicine. Harvard is also stating that remdesivir is showing promise in a laboratory and may be brought out in clinical applications. Donor plasma is another option. So somebody who has had COVID-19 and has recovered, we can check their blood for the antibodies. If the antibodies are high enough, we can draw their blood, we can spin out the plasma. The plasma will have the antibodies against corona, and then we can inject that to somebody who has a compatible blood type, and that'll help the person get through the disease faster. And of course, that blood is always screened for other infectious diseases such as HIV. High-dose vitamin C is being used in medical centers, high-dose IV vitamin C, and that's showing a lot of promise as well. So some miscellaneous information I want to provide. Ibuprofen was reported by the French Health Ministry as something that should not be